So we have had a lot of discussion on TGAs, delayed switches and sendings, so whether to operate or not to operate, and if we operate, what we have to do and all those things. So this is just a revision on all the previous lectures that we had. And I would like the audience to actively participate in this. It's a didactic session. So this child was a preterm 34-weeker 1.2 kilogram female. He was one of triplets, had breathlessness on 10th day of life and cyanosed. So he was treated elsewhere, diagnosed to have congenital heart disease and referred to our hospital. So at presentation to our hospital, the child was 3 months of age, weighing 2.8 kilogram, mildly tachypnic, saturating 75%, warm extremities. The rest of the examination was uncharacteristic except for a grade 3 ESM at the second level. So here is a chest X-ray just for showing you the classical X-ray of transposition. So the echo showed transposition of great arteries. There's a PFO with an additional ASD. There was an intact ventricular septum. The LV surprisingly was well prepared. The RV was hypertrophied and the coronary anatomy was normal. So this is the echo, which is again showing the anatomy. You can see the transposition clearly, the intact septum. Dr. Nagesha has basically summarized what the checklist that we should go through. So it's basically look for the VSDs. We looked at VSDs carefully, different views, no VSD was found, and ductus was carefully looked for. There was no PDA, and there was mild bilateral peripheral PS. The actual size of the measured size of the pulmonary arteries were adequate. Only the flow acceleration were there. So we thought it should be fairly okay to go ahead. There was no significant aortopulmonary collaterals or aortopulmonary window. And as we thought that RV looked relatively small, the tricuspid annulus was measured, the size was okay. So tricuspid annulus of 10.2. So surgeons were fairly confident, so we decided to proceed with an arterial switch operation. The coronary anatomy was normal. We had a bypass time of 240 minutes and cross clamp of 140 minutes. Though we found the LV prepared, we were little concerned, so we thought of reducing the afterload very much. So we added milrinone and phenoxybenzamin when we came off bypass, and a touch of epinephrine. So the blood pressures were 65/30, heart rate of 130, and CVP of 4 millimeters of mercury. Contractility looked very good, and the sternum was closed. So this child was brought to the ICU with pretty stable hemodynamics, but within the first 12 hours, there was a slow progression from warm extremities to cool peripheries. The blood pressure so far remained okay around 63 to 76 and diastolic pressure of 29 to 39. CVPs remained well below 5, but the peripheries became extremely cold, peripheral pulses were feeble, and the urine output substantially dropped to 5 ml per hour. But by then, within 2 hours, the surgeon was concerned, so a prophylactic PD was already inserted. So we didn't have much hyperkalemia which is associated with that. And the blood pressure showed a fairly higher lactate levels, which failed to settle in the first 2 hours. On day 1 morning, this was the scenario. The patient had hypotension with BP dropping to 39/20s, CVP of 6. Patient had low urine output and high lactate levels. So I would like to again break the for a short discussion. So at this point, we have a transposition which is fairly older child with an intact septum, developing a significant low output in day 1. And LV function was not very bad. What are the other possibilities that could be there? So we couldn't find any other possibility at this point of stage, so we had to go ahead with some sort of management strategy. The surgeon was fairly confident of the anastomosis, so he was not willing to open the chest. So we reduced the dilators because he was on too much afterload reducing agents. He was on phenoxybenzamin as well as milrinone. We thought patient was dilated, so reduced the dilators. Stepped up our adrenaline doses. CVP was only 6, so we tried more volume, but it didn't produce much difference. It increased the CVP to 10, but did not contribute to improving the pressures. Peritoneal dialysis was added.